Hello, and welcome to the Health is Fluid webinar series hosted by ImpedMed. Today's webinar is about breast cancer survivorship, lymphedema, and preserving the whole patient. My name is Joanne Yao, and I am the Senior Director of Marketing for ImpedMed and the moderator of today's session. We appreciate you joining us this afternoon. October has long been recognized as Breast Cancer Awareness Month. And thanks to science and significant advances in medicine, we are now seeing more and more survivors. This brings an increased focus on survivorship for clinicians and patients from the time of diagnosis through treatment and beyond. We have a very exciting panel discussion planned for today and are looking forward to a lively and informative discussion. We encourage you to participate by submitting questions via the Q&A icon on your screen. We will do our best to answer as many questions as possible during the hour, and we'll follow up with any questions we are not able to address live. So without further ado, I'd like to welcome our panelists for today's discussion. Our panel today includes Dr. Elizabeth Shaughnessy, breast surgeon at the University of Cincinnati, Dr. Sheri Prentiss, occupational an environmental medicine physician and founder of the Live Today Foundation, and Julia Cameron, occupational therapist and center manager at the Baylor Scott and White Institute for Rehabilitation. Thank you all for taking the time to join us for today's discussion. I'll start by giving each of you an opportunity to introduce yourself to the group. Dr. Shaughnessy, would you please begin by telling us your story and experience with breast cancer and lymphedema?
Okay. Well, as you may have already seen on the introductory slide, I am a surgical oncologist. I'm at the University of Cincinnati, trained in Chicago and in the LA area. I was always very frustrated at my patients' frustration and angst when they developed lymphedema. So this was something that was already on my radar, and I would also give talks in the community. However, you know, we are human as well. And breast cancer came knocking on my door in 2019, and I was left with some degree of lymphedema. But I had already taken some baseline measurements in terms of bioimpedance before I had my surgery, and measurements again afterwards. But I did physically notice that there was a fair amount of fluid on the upper end of my arm. Which gave me some distress. I am a surgeon. This is what I do, and I didn't want to be disabled. And so this has become even more near and dear to my heart, and I make sure that I'm sufficiently aggressive in asserting my patient's interest.
Thank you, Dr. Shaughnessy. Julia, would you please introduce yourself and tell us about your practice?
Yes, I'm an occupational therapist, certified lymphedema therapist, and also LANA certified. I am Revital Cancer Rehab trained. Revital is our nationwide comprehensive rehab company through Select Medical. And why that's been really important to me over the years is 18 years ago when I was brand new to this profession in rehab, I had a patient that came in with a diagnosis of shoulder pain. And at that time, she had on long sleeves. And when she raised her arm and her sleeve fell back, I saw that she had a very large arm. At the time, I didn't know why, but I did some research, and that was kind of the beginning of my journey. And I became very passionate about helping cancer survivors and working with people who have developed lymphedema, because she was sent to me for shoulder pain. And if I didn't go through the process at that time, I took a lot of time to really research and investigate, lots of nights looking up things to figure out what is really causing this, because it was disabling for her. And I don't think anyone should have to live that way. If there's something that we can do to prevent this, or something that we can do even to help the person if they've already arrived at that stage by the time we see them. So I've really made it one of my missions with occupational therapy. I'm now a clinic manager for Baylor Scott and White Institute for Rehab. We see over 4,000 patients a month, not all oncology related, but 24 of our clinicians, PT, OT, and speech included, are Revital Cancer Rehab certified, because we have a great passion and mission to serve our communities and to help others live well with cancer or after cancer.
Thank you, Julia. And Dr. Sheri, would you please tell us about yourself?
Yes, I'm Dr. Sheri Prentiss. I have been a physician now for nearly 30 years. I always wanted to be a doctor ever since I was 2 years old. I am an occupational and environmental medicine physician that is predominantly workers' comp. It is not the same as occupational therapy. And I've been able to enjoy wonderful positions as, global medical director of medical operations for Hospira and program medical director for occupational and employee health for the largest healthcare system in Illinois, and was living a wonderful life with a beautiful family until October 1st, 2008. And that's when everything changed. I found a mass in my right breast, underwent a partial mastectomy, 15 rounds of chemo, 33 treatments of radiation, and unfortunately was one of those individuals who ended up with chronic debilitating lymphedema. I'm wearing my glove. I decided to bling mine out because I figured if I got to wear it, I might as well try to look cute and raise awareness and draw attention as much as I can. And but what I found when I developed the lymphedema, I became disabled from clinical practice. So my career and my lifelong dream was stripped from me in an instant. So I had to completely reinvent myself. So I stepped a little bit further into the health equity space, had been in health equity my entire career, but I went even a little further and became the national spokesperson for Susan G. Komen for their 3-day program and became the first national ambassador for their health equity initiative. And during that time, I had to completely reinvent myself, guys, because I couldn't do clinical practice anymore. So I became a professional speaker, a certified speaking professional, started my own healthcare consulting business. But in my travels, I noticed that there were too many patients out there that were living with lymphedema, and most didn't even know what their diagnosis was. They just knew that their limb was swollen, and certainly not knowing what it was, they weren't getting treated. So I started the Live Today Foundation that serves 3 primary purposes. 1, to educate physicians and other clinicians on how to properly diagnose lymphedema and make them aware of all of the psychosocial impacts of lymphedema on a survivor's life. Secondly, to educate patients about the importance of lymphedema and to explain to them what their diagnosis is and what it means. And then number 3, to provide free compression garments to under-resourced cancer patients and survivors living with lymphedema. So I'm very grateful for this opportunity to have a partnership and a discussion with ImpediMed to discuss a condition that sorely affects survivorship amongst cancer patients, but we have the opportunity to do something about it.
Thank you. Thank you all for your introductions. And again, for those of you on the audience, please don't hesitate to submit questions if you have any questions for our panelists. Let's go ahead and get started. So, this topic today is survivorship as part of Breast Cancer Awareness Month. And we all are very happy that the improvements in early detection of breast cancer and treatments have dramatically improved survivorship rates. So Dr. Sheri, the first question is for you. From a patient perspective, how should patients approach their breast cancer treatment with survivorship in mind?
I will start by saying this. I understand a patient's fear when the diagnosis of cancer is given, better than I ever could have experienced only as a physician rendering the diagnosis. But I also now, in retrospect, realize that patients need to be cognizant and aware that they will get through treatment, and there will be a time that will define them as a survivor. So their quality of life as a survivor will be paramount. Therefore, I encourage patients, and I believe that patients need to empower themselves and push back on their doctors and get answers to questions that address, what will life be like after I'm done with treatment? And what can I do to minimize my risk for certain complications associated with my treatment? And certainly we know that lymphedema is a significant, can be a significant complication associated with their treatment. And so I would encourage patients when they're thinking about survivorship to think about life beyond that initial treatment stage. I know we stay focused on the treatment phase because when you're thinking about it, it's a 9-month to a 1-year ordeal. It is chemo and it is radiation and it is appointments. And I get that and I understand that. But be able to think about the entire picture and trust and believe from other survivors. I and Dr. Shaughnessy on this call, we survived it. There will be a time on the other side of treatment. And so now I encourage anyone on this call to really think about how will my life be after I'm done with the treatment. And the only way that you can really grab hold of that and take ownership of it is to ask the questions at the beginning, because there are things that you can do that will alter your course after treatment is over. And little simple things can make a mass difference in how you live life afterwards.
Thank you, Dr. Sheri. And we did have a question come in for you.
Okay.
There is interest from the audience in knowing where they can learn more about your speaking.
Oh,
is there a place that they can go to? They
yes.
love your bling
Thank
and
you.
want to know where they can learn more.
Okay.
Where can they go online?
They can actually go to my website. That's www.drSheriMD.com. That's DRSHERIMD.com.
Thank you, Dr. Sheri, and thank you for your answer. You know, if you're asking a patient to think about survivorship at the time of diagnosis, when the stress that you're describing they're under is tremendous, how can physicians and healthcare professionals help that patient from the very beginning thinking about survivorship? And Dr. Shaughnessy, I'll start with you for this question.
Well, you know, now having been on the patient side of things, I found that as doctors, we're doing less than an adequate job. I think what we need to do first and foremost is realize that the patient in front of you is paralyzed sometimes by fear. They're trying to do the best they can to focus on all these points. And there's a lot of discussion around treatment. And certainly we're trying to keep it simple because it's hard to absorb. But there are going to be specific implications about some aspects of our treatment. And yet, in focusing on just the main points, I think as patients, we've lost track of who do we need to talk to when this happens? How can I make this better? Or is there something I can do now to help minimize it? Just like Dr. Sheri had mentioned, as it's difficult because there's not that much information out there in which patients can access in terms of the amount of questions that perhaps they should bring in to talk with their physicians. I think that individual breast cancer programs, might be wise to perhaps connect the patients with a survivorship program even before the treatment is through, so they can start to understand what this survivorship program could do, or at the very least connect with a nurse navigator who can give them tips or advice on how to manage the problems, and be a contact person or a triage person when some of these problems arise. I mean, being that lymphedema may not be that common, but it certainly has a huge impact on one's quality of life. Knowing how to making sure you've got baseline measurements before you've even undergone therapy, and therefore have arrangements for serial measurements afterwards. And then there's a whole question of prehab, which I think Impediment is going to address in a future webinar.
Yeah, thank you. Thank you, Dr. Shaughnessy. Julia, can you tell us a little bit more about what you're doing from a prehab perspective?
From prehabilitation, I like to think of it as more of a multidisciplinary approach that comes in alongside the patient, preferably before they begin their cancer treatments, but as soon as possible, whenever we're able to come alongside this person. If you're thinking, well, what is prehab? I like to think of it as a storm. You know, if we know that a storm is coming, we may go out and buy groceries, and we may, depending on how bad the storm is, prepare the windows, things of that nature, but we make preparation for what we know is a possibility. And if you think of a storm in regards to prehab, before you take this medical journey or walk into this medical storm, we are here as your healthcare providers to be able to prepare you, to say, you may notice that your arm might feel a little bit heavy, or this may become a little bit tight, or, you may become more fatigued. Having those conversations about how some of these things may happen, but just as a storm passes and you rebuild, this medical issue will pass and we're going to rebuild. So see yourself a year from now. Where do you want to be? What do you want to accomplish? Because I think if we keep the end in mind, that it gives the patients hope, but it also lets them know we're not here today and then we disappear tomorrow, but we're here to walk the journey with you. And we also have very skilled people adequately in place along the journey to help you figure out and really walk through the maze to see what's next. And oftentimes, I guess I would, recommend to patients as well as healthcare survivors that, I've had patients say before, well, I just didn't ask because I'm so thankful to be alive, but now I wish I had known. And so I feel that prehabilitation and prospective surveillance, a lot of these things we're doing now are because we're listening to our patients, we're listening to the community, and we're taking the I wish I had known, and we're building programs around that. So that with survivorship in mind, there's opportunity. There are things out there. So don't settle with being thankful to be alive, and ask what else can I do? What else is out there? And challenge the medical community to help you move through the process.
Thank you, Julia. That's it's very informative from both of you. Now, we are getting a lot of questions about lymphedema, and we're going to get into lymphedema in our next topic. So I'm going to hold those questions. But one of the questions that we are getting a couple of questions around prehab. And one of the questions is about insurance coverage. So I guess, Julia, just what is the kind of current status of insurance coverage for prehab appointments? And is there an opportunity for expanded coverage if it's not covered today?
Well, when you're billing prehab through physical therapy, occupational therapy, or speech therapy, it is covered through your therapy benefits, because the person actually has a diagnosis of cancer, or they have some have a diagnosis of lymphedema, but when you're in prehab, you have a cancer diagnosis already. Therefore, if your visit limits for physical therapy are 20 visits, that prehab is part of those visits and it is covered. If someone doesn't have therapy benefits, then it's not covered, but then again, no therapy is covered. So it's really very dependent on insurance plans. But from prehab itself, it is covered. It's just a different mindset. It's been covered for years if you had an orthopedic diagnosis, and now we're taking that same care model and looking at it from an oncology perspective.
Thank you, Julia. That helps a lot. So let's start talking about lymphedema. It's coming up in the Q&A, and as we've discussed, lymphedema has been called the most feared consequence of breast cancer survivorship. So before we begin our panel discussion, Lisa, could we launch the first poll question? So we have a poll question for the audience. Please go ahead and answer kind of your current thoughts around lymphedema. And as we're going to give about 30-45 seconds for the questions to get answered. While those come in, Dr. Shaughnessy, we'd love to start with a question for you. That as a breast surgeon, what are you doing to reduce the impact of lymphedema on your patients?
Well, as I did in my own care, I want to make sure that we can find this extremely early, even before patients develop symptoms, because the data would actually support that this is where we're going to have the greatest impact. People who present with an extremely large arm that has been chronically large, there isn't a whole lot to do that we can, there isn't a whole lot we can do to completely reverse it. However, if we can intercede before that becomes even manifest, we can help keep the arm relatively the same. Although it's a bit of a maintenance program, if we if we've recognized this, then we can get the patient in for the appropriate therapy with a lymphedema therapist. So what I do is I make sure we get a bioimpedance measurement, which is what I got, which you can get with our SOZO equipment before the surgery. And then after they come back for measurements, I have them checked every time we see them in follow-up. So therefore, I can detect when there's perhaps a jump, and we can perhaps identify what's going on. Now, this is really most appropriate for our for extremities, but certainly inspecting the tissues to see if there's any other further types of lymphedema, because you can have it on the chest wall, you can get it on the breast, and it can take, majority of people present within the first 2 to 3 years, so it may not be manifest right away. So you have to be monitoring this along the way.
Thank you. Thank you. And, we've got our poll. I'm going to go ahead and share the results of the poll. Can everybody see that?
Mm-hmm.
So interesting from our audience, we have about 3/4 believes that secondary lymphedema is preventable if detected and treated early, what you were discussing, Dr. Shaughnessy. About 1/4 believe it's not preventable but treatable, and then those look at once symptoms occur. And so what you were discussing, Dr. Shaughnessy, is kind of that first bucket, a prospective model of care. Julia, would you talk a little bit about what a lymphedema prevention program is and how you're doing it at Baylor Scott and White Institute for Rehab?
Sure. When we bring the patients in their first visit, we're looking at their range of motion, their overall function. We're also taking a SOZO measurement because it's very important through the process that we want to go ahead and know what their bioimpedance scores are at their baseline. Our goal is absolutely to see them before surgery or cancer interventions, but if not, we still, as soon as we do see them, we're working through that. Because with rehab, we're taking them through a series of lots of education, mobility. We're also teaching them strength after breast cancer, to where, what can you safely do without giving yourself lymphedema, because that seems to be a big fear at times, that some patients stop exercising because they're afraid that they're going to develop lymphedema. So instead, we help to dispel that myth and really help a patient move through and regain control over their life by having a greater understanding and being able to self-monitor through what is most appropriate and what's the best way to build strength and conditioning at this point in their life. And the SOZO is very helpful there, because it's not just circumferential measurements that we're taking, because now we have clinical data through a device that really allows us to truly see, without the inter-rater reliability, what is going on. So when we have early values and then work through a process with the patient and then take later values, we can see how the patient is doing. I will also say, when you have clinical data like that versus just my professional educated opinion that I'm giving to a patient, it increases the patient's compliance. If I were to suggest that they needed to wear a sleeve, they can see that the numbers on the device for their bioimpedance scores are changing. It's not just me saying, well, when I measured you, this changed. And I do believe that really helps, because we all know that one day I could measure a little tighter, or one day I could measure not as tight when I'm doing circumferential measurements. And patients can self-justify that if they don't want to wear their sleeve, or if they would like to make a different decision. But with the SOZO, there's not an ability to have that inter-rater reliability. This is what it is. And it just really helps to empower the patient to say, okay, I made these choices and here's the result that I'm able to get. So I'm going to continue to make these choices, in a positive direction.
Excellent, thank you. Now we have an interesting question come through, and Dr. Sheri, I'm going to ask you to think about this one. We have a question about concern or caution of using the word prevention. Because in the model of care that we're discussing here, we are detecting lymphedema at an early stage 0, and preventing it from becoming chronic. So, how would you consider that in your mind? How are we preventing lymphedema?
Mm-hmm. Great question, and I appreciate the question and the desire for clarification. Let me first step back and state, for those that are on the call, they may not recognize or appreciate, lymphedema occurs in stages. Okay, so it's a buildup of the lymphatic and fluid that causes painful and sometimes chronic debilitating swelling of the affected limb. So when you go from stages 0 to 3, what we are talking about as far as preventing, we're talking about preventing this debilitating chronic lymphedema. And in so doing, we are detecting, we're using a clinical assessment tool to detect lymphedema. So we're not stating that it's not there. We're detecting lymphedema early on in those stages, stage 0 and potentially stage 1, because if we can catch it during those early stages, that first 2 stages, 0 and 1, we have the opportunity to treat them with some simple at-home care, wearing compression garments for 4 weeks. But unfortunately, most patients don't come in until the swelling has already formed. By this time, they are typically at stage 2. By the time you get to stage 2, lymphedema becomes a chronic condition that you have to deal with for the rest of your life. So we're talking about using a clinical assessment tool that will allow us to detect lymphedema early enough so that we can intervene and prevent it from becoming a chronic debilitating disease. And I hope that provided the clarification that the individual was needing when we talk and use the word prevent.
Yes, thank you. I think that's extremely clear and really helpful. A couple other questions about lymphedema. Dr. Shaughnessy, we have a question from the audience that the surgeons in this audience members group tell the patients that since they're only doing sentinel node biopsy, they do not have a risk of lymphedema. Is that true? What's the reality behind lymphedema and sentinel node biopsy?
False. Sorry.
False.
It's the case that by doing a sentinel lymph node biopsy, it minimizes our chance of getting lymphedema, but it does not completely avoid that chance. The studies have shown that the incidence of lymphedema following a sentinel lymph node biopsy is somewhere between 5 to 7%. And certainly it's not on our radar, but I've seen patients develop it. And one of my recent patients who is a nurse over in the same day surgery area that I see just about every time I operate, had a sentinel node biopsy. She had a single sentinel node. She has small amounts. She has very early lymphedema, but we found it. We identified it early. And she was in the lymphedema therapist's office within a few days. And so we are taking measures to make sure that this isn't going to progress and that she remains the way she is. But no, it can happen. It's just not very frequent.
And thank you. And I'll also point the audience to a recent publication. Actually, yesterday, a subgroup analysis was published from the PREVENT trial. For those of you who are not familiar, PREVENT is a randomized controlled trial comparing BIS to a tape measure on being able to detect lymphedema early and prevent its progression. The final endpoint is due out next year. It has 3-year follow-up, but the subgroup analysis looking at lymphedema through 2 years looked at the impact of radiation and the incremental impact of radiation following surgery, and did in fact show that following sentinel node biopsy, if that patient goes on to get additional therapy like radiation, that of course also increases their risk of lymphedema. So one thing to think about is the surgery is important, yes, but also the total treatment, the other treatments the patient is getting have an impact as well. We have a question, Julia, maybe you can handle this one, is a friend had her lymphedema, it has lymphedema in her torso. Mm-hmm. But her doctor told her it couldn't spread. Any thoughts on the progression of lymphedema? And if you're getting it in your torso, could you also get it in a limb?
I would say yes, that you could. When you are looking at the anatomy of the lymphatics, if you have, I mean, your main lymph nodes are going to be in your neck area, your axillary region, and in your groin area. So if you have some damage to, let's say, more your armpit area, and you have breast lymphedema or torso lymphedema, then oftentimes over time, if that area gets large enough, you can have some spillage over into your arm. Sometimes you don't see that. If someone's been radiated quite a bit, it may have scarred down the area enough to where that pathway is not going into the arm from where you're having your accumulation of fluid, and instead it's just really building up in that breast or you know, in the abdominal area, depending on the type of reconstruction that someone has had. So it's not impossible. Oftentimes, if you have it in your torso, people down the road will tend to have a little bit more edema in one of their extremities and, you know, nearest to the area of injury. So I would say that it's definitely possible. You just don't see it as often if the edema is needing to pass over the scarred area to get to the arm.
Interesting. Thank you, Julia. Let's talk a little bit more about program implementation. So, Lisa, would you mind launching the next poll question? So we're going to put up another poll question about monitoring for lymphedema. A lot of what we've been discussing here is that we're monitoring to identify lymphedema early so that we can detect it at the stage 0, as Dr. Sheri discussed, Dr. Shaughnessy discussed, and prevent it from becoming that debilitating chronic condition. Julia, can you talk a little bit more about kind of the approach that you're taking in more detail, some of the tools that you're using, the testing protocol, what you do for treatment and patient education?
Okay, yes. Right now, when a patient comes in for their first visit, we are either using the SOZO, we're offering the SOZO to all patients. There may be some questions on finances. Some insurance do pay, some insurances do not cover the SOZO at this time. Therefore, if it is a payer that does not cover it, we make sure that the patient is aware what the cash pay price would be and give them the opportunity to choose. We continue to do circumferential measurements as well for those patients who choose not to use the SOZO technology. That's kind of our beginning as far as monitoring lymphedema. We do a series of questions as far as their history, and then really educating them on their risk factors, like what are their personal risk factors? Because the more comorbidities someone has going into their disease process, that also increases their chances of developing lymphedema when their other systems may not function as well as someone who was completely healthy prior to a diagnosis. So we definitely start there for monitoring lymphedema. After that, we do teach the patient some different breathing techniques. We do teach them how to do just some very small manual lymph drainage to the main areas that are closest to the area that's affected. So that, because that's something that a patient can do in 30 seconds. That just kind of helps their body have a jump start. And proper abdominal breathing definitely can help get, you know, a lot of visceral movement as well as just lymphatic movement throughout the system. Think of it like priming a pump. And so if they're doing those things just for general health when they don't have lymphedema at this time, those are just some tips and tricks that we teach them. If they have no other issues and they don't have shoulder pain and they don't have any back pain, oftentimes from there we look to see where they would like to be in the future. And we look at what was their activity level prior and just monitor them throughout the process. We either help get them stronger than they were before, or, you know, where they are currently or where they would desire to be by following more of the strength after breast cancer approach, all the while monitoring their symptoms and spending lots of time educating them on different side effects and expectations depending on if they've had chemo or if they've had radiation or if they're in that current process, because someone's body is going to change and their reaction to their treatments changes throughout the process as well.
Thank you. Thank you so much. Now I'm going to share the results from the poll. Can everybody see those? So interesting here, we've got 60% of the audience is using tape measure, 40% is using BIS for all at-risk patients, 16% using BIS for some patients, and keep in mind this is a select all that apply question. Some are not using BIS and some do not have a protocol at all. So Dr. Shaughnessy, I'd love to kind of get your thoughts. What would you say to the folks that are either not measuring all of their patients or don't have a protocol in place for lymphedema?
My experience as a surgeon is that you really can't easily predict who's going to be developing lymphedema and who isn't. And it is in part treatment related. I personally am not trained as a lymphedema therapist or as an occupational therapist focused on that. So I don't feel at all comfortable doing tape measurements. At one point in time in the past, we were doing what's called water displacement. But quite honestly, that is quite messy. And in this age of COVID, disinfecting the equipment would be amazingly difficult. And you have to change it between each patient. I liked the whole concept of the bioimpedance measurements because there's very little variability between one person performing it and the next. And it was a way we could help to communicate at least fluid accumulation relative to the patients in interacting with our lymphedema therapists. It was something we could do. No, I realize it's not diagnostic of lymphedema, but it gave me a much better indicator of when I should possibly be intervening and getting this patient to somebody who's trained in the field, who can evaluate and possibly treat the patient for that particular problem. And so we've instituted SOZO machines and a SOZO measurement's taken with your vital signs. It's relatively easy to do.
Mm-hmm.
Thank you. Dr. Sheri, we've got a question here about knowledge of lymphedema among even medical professionals. It's pretty scarce. What are your thoughts when you're educating about how do we educate the medical professionals specifically better on both lymphedema as well as what's available to help prevent the chronic condition from developing or to treat patients that have it?
Great question. And my history is such that it was my radiation oncologist, meaning I went through my breast surgeon, I went through my medical oncologist. It wasn't until my radiation oncologist that I even heard the word lymphedema come up. And at the time when I was told it was only 1 to 2%. Well, those of you on this call, we know better that 1 in 3 cancer at-risk patients, survivors will develop lymphedema over their lifetime. 50% of them will develop it within the first year. And so now that we've educated ourselves and have better research and numbers under our purview to know just how vast this is. That's 300,000 to 500,000 cancer survivors being diagnosed with lymphedema every year just in the US alone. We as physicians who got into this altruistically because we want to be a help to patients cannot turn a blind eye to this. And I'm going to piggyback off of what Julia stated when we were talking about patients thinking with the end in mind. Their end, as a physician who is treating a patient, we need the physicians to think that the end is for them to live, not just survive, but to live. And so how will they live after this? So if living is just removing the cancer and that's all we think about with that patient, then we're doing that patient a disservice, because that's not taking into account the whole patient. And when you take on a patient, especially when you are taking on a patient and you have rendered the diagnosis of cancer, there, to me, should be a certain level of responsibility, if you will, that I want to make sure that this patient is whole when they leave me. And what can I do to ensure that that patient is whole? So now you have the opportunity now, when you're doing your CMEs, you're getting educated. You're on this call right now, you're getting educated about lymphedema. But I think one of the ways to further educate physicians about lymphedema, diagnosing it, and making them aware of the psychosocial impact is to one, appeal to their emotionality that goes beyond the book sense. The books say this, the research says this, and then I'm supposed to take them from this algorithm to this. Just stop and look at that patient and think and realize that's a mom who has to take care of children. It may be a single mom and she's a cosmetologist and doing hair is what she does. That's how she makes her living. Well, you slop her with chronic debilitating lymphedema, guess what? She's not doing hair anymore. So now what's going to happen to her and her two children? And so as physicians, we have a responsibility to make sure that that patient is cared for. This is not an assembly line. This is not, okay, I'm the breast surgeon. I remove the breast. Okay, on, next. That's not how you're thinking. Every physician that touches that patient's case, breast surgeon, medical oncologist, radiation oncologist, if you send them to a physical therapist, everybody needs to be thinking about the survivorship and how that patient will live once they are beyond this hurdle. Because we have been in the position where we have seen patients get beyond the hurdle. So we see things and we are aware of things that they're not aware of. So we need to make them aware of it. And if we don't, shame on us. And I want to put the doctors that may be on this call, shame on you if you don't think about that. At the end of the day, you need to go to bed knowing that I've done everything I could to educate my patients, to give them the best possible resources, and to ensure that they can live beyond this cancer diagnosis.
And one of the things we hear is the concern that a patient's just been diagnosed with breast cancer. Like you said at the beginning, they're getting a ton of information. They may not be able to absorb it. We don't want to scare them. Dr. Shaughnessy, what is the reaction to patients when you educate them on lymphedema early, get them measured, a baseline measurement? How are your patients responding to the efforts you have around lymphedema?
I've actually had them thank me, which is really quite interesting. Some of them said, I've never heard of this before. I've never heard of this. What's lymphedema? And so it strikes a whole conversation. And many then become very proactive about making sure they get their measurement, or what was my measurement? Was that okay? I like that. I think that being very proactive about their care. And that's really what I've only encountered favorable measurements, although there's been some degree of, discussion about how is this covered, because there's a lot of problems having to do with insurance companies and how are they going to cover that. So we're trying to iron out and clarify amongst our providers who requires pre-authorization versus who doesn't.
Thank you,
Joanne, can I piggyback off of that real quick?
Sure, please.
When Dr. Shaughnessy pointed out that when she tests patients and they say to her, oh my God, I didn't even know what lymphedema was. Thank you. First of all, oh my God, had I been one of your patients who had access to bioimpedance measurements, my life would be very different now. But let me also state that because of the efforts of webinars like this, and because more and more discussions are getting out there about lymphedema, patients are getting educated. And what we're going to start seeing now are patients coming in asking the questions, because when you realize what lymphedema can do down the line, there's this added fear now of, well, what can happen? Okay, once I get through surgery, you mean to tell me I can end up with life where I lose my job? And if I can't take care of my job, I'll lose my house, I'm gonna lose my car. And so now physicians, you now need to arm yourself with the knowledge, because now your patients are going to start asking you about it. And you need to be mindful and sound real intelligent when you can speak to what it is, how to diagnose it, and how beautiful, what a savior you could be when your institution has the facilities and the wherewithal to do this type of clinical assessment. And so I would encourage physicians to, one of the things that I hated to be in a position was to have a patient ask me a question that I needed to respond, I'll get back to you later. That's just not appropriate in our line of work. We want to be on the ready. So any physicians out here that are on the line, Get yourself armed with this knowledge, because you're going to have more and more patients coming at you asking, I'm hearing about this lymphedema. This is a risk that I heard that was possible. What could happen? What can I do? What can I do to prevent it? You want to be ahead of the game, being able to give your patients all the answers that he or she needs.
Thank you, Dr. Sheri. Really appreciate that, and both of your comments on the impact on patients, and that many patients find it supportive to learn about the resources available to them versus scary. You know, we're getting some really, really technical questions. So Julia, I'm just going to ask you to hammer these out.
Okay.
And there's three of them. One of them is, what's your treatment protocol? Optimal. Second question is, if you can't get a baseline, how do you know if lymphedema is developing if you only see the patient after treatment? And then third question is, how do you differentiate an LDEX increasing due to lymphedema versus another cause? So 3 pretty technical questions related to the program.
Okay, so let's start with, I guess it was a lot all at once. So how do we differentiate between just lymphedema or it not being lymphedema, possibly something else? A lot of times that's through history collection. You know, if they're immediately post-surgery, a week or two, that can be, you know, your surgical lymphedema, or edema, I should say, not lymphedema at that point. So we're waiting to look further out. Are we wondering if, I think looking at the clinical presentation, is this edema in this one extremity or on the side of the body where the breast was most impacted? Is the patient getting radiation, or are you seeing a global edema? Some people may have other issues. They may start to have cardiac issues or renal issues, or are they having an adverse response to their chemotherapy? Do they have full body swelling? Is it bilateral or unilateral? Oftentimes with lymphedema, not always, but most of the time, you're going to see it unilateral on the most affected side where the surgery occurred. You're not typically going to see full body swelling unless you have another issue going on. You know, so when you're looking at your LDEX numbers, I guess another question was, if you didn't get baseline measurements. Well, ask the patient some questions. Hopefully, you know, a lot of times patients may or may not be the best historians, but the ladies can tell you if their shirt sleeves fit tighter or looser than they fit now. They do know that. They're very aware of, you know, how their clothes fit. They're very aware of, is their arm uncomfortable? Does it just feel heavy? You know, just some subjective questioning can lead you in that direction. Also, circumferential measurements, although there may be some inter-rater reliability, if you measure them, you know, take measurements of one arm and measure it to the other arm, the arm that's not at risk, and your at-risk arm is larger, there is a strong chance that you're beginning to develop lymphedema. I did actually today, I had a call from another practice where they were seeing an oncology patient, and the clinician called me and said, okay, I was doing circumferential measurements. We don't have a SOZO. And I noticed that of the 6 measurements I've been taking, because she just takes kind of spot check measurements, she's gone up by 0.5 at every spot. What do you think? She said, I'm not a lymphedema therapist. Will you take a look at her? I said, absolutely. So she sent the patient over, and just out of curiosity, I wanted to see. So we did every 4 centimeter circumferential measurements and found that she had a 200 millimeter difference volumetrically. Now, it could be discussed, debated in the literature, and in all kinds of ways. Is this because that arm is her dominant arm? Is it just a little bit of edema? Is this lymphedema or not? However, put her on the SOZO, and it shows you right there, she's out of the clinical range. She's not within the 10 points. So I could absolutely say, yes, we are in the early stages of lymphedema. We do need to go ahead. We've tested, you know, this test shows that she's triggering and showing that she is actually having symptoms. And so now we need to treat her. So that way she does not move into more of a chronic stage of lymphedema. So I would consider that us preventing her from moving into chronic debilitating edema, not necessarily preventing the edema itself. But without the SOZO in previous practice, that would have been a debate. Do we put this person in a sleeve? Do we not? Was this person already have a stronger arm on this side? Do they not? And we might have let this person go on another 3 or 4 weeks and measured them again and said, oh, well, now we're even bigger before they were treated. Because sometimes people will look perfectly normal, even if they're 200 milliliters above, and they'll still look good on the SOZO. It really depends on their personal body makeup and your comparative numbers. In this case, she absolutely has lymphedema, and the SOZO confirms that. So I think that's where it becomes very valuable in clinical practice. Now, hopefully I answered all 3 questions. Did I miss one?
There's one more.
Okay.
What's your optimal measurement protocol?
My optimal measurement protocol would be pre-surgery, 4 weeks post-surgery, and then every 3 months for the first 3 years, and then we would follow up from there. We're really following the prevent articles and publications through ImpedMed for how we're monitoring lymphedema.
Thank you. Dr. Shaughnessy, what about you? What's your optimal protocol for testing?
We're pretty much following exactly what she just said. And that's the frequency in which we're seeing our patients post-operatively.
Thank you. All right, it's interesting. We've had a couple questions come in, folks asking for some additional resource information. So I'm going to go ahead and provide some of that before I send the next question over to you, Dr. Sheri. We have a patient who is undergoing breast cancer treatment right now who has concern about the onset of lymphedema. We can refer you to a couple of resources online. If you go to impedimed.com, we have an LDEX provider tool. You can go into that, enter your zip code as long as you're in the United States, and it will give you the locations of your nearest LDEX provider. Additionally, if you go to Learn, the Lymphatic Education and Resource Network, they also have tools for finding providers and lymphedema therapists. So there are a number of different tools out there available for patients to find therapists and find providers who offer SOZO and LDEX. Thank you for asking the question. Dr. Sheri, we have a question about your organization as well, Live Today. And so I wanted to ask you to talk a little bit about what resources are available to patients. And this specific question is asking whether you can work with under-resourced patients nationwide, and if so, how they might get in touch with you.
Great questions. I mean, we have some fantastic people in this webinar because these questions have been on point. The Live Today Foundation, we provide a number of resources. And if you go out to the website, it's www.live-today.org, live-today.org. We have a number of resources out there. One of the additional resources that Joanne mentioned, the Lymphedema Education and Research Network, i.e. Learn, also has tons of resources on their site. And yes, we are a nationally recognized nonprofit. So we help individuals, under-resourced individuals across the country. I mean, we go east, west, north, south, we get contacted, and there is a contact form on the Live Today website where if an individual wants further information, if they want the free compression garments, all you do is simply fill out that contact form. It's a simple email that comes to my staff. My staff reviews it. We have partners that are partnered with us for compression garments. We have a simple method where we send you back a link where you can properly measure yourself. A lot of individuals have, been to an individual like Julia and have already had their measurements. It's just that their insurance company won't pay for the garments, or they don't have insurance. And so they'll have the measurements but can't do anything with it. And so we'll have them, they'll send in our measurements. We coordinate with, whatever partner we're dealing with at that particular time. They get a link that gives them the opportunity to select which types of garments they want. They can have different colors and designs, and those garments get shipped directly to the patient. And so, yes, if you have a health system, a hospital, a program, a cancer support program where you're looking for additional resources, and lymphedema and compression garments seems to be one of your biggest hits, but you don't know of of a place where they could get free compression garments, they can contact the Live Today Foundation. That is one of our primary responsibilities, and that is getting these free compression garments out. Now, I'm hoping that Live Today, that portion of it won't need to be needed in the years to come, because we're going to knock out this chronic debilitating lymphedema, and maybe I'll only be providing free compression garments for those initial first 4 weeks, because we'll catch it in stages 0 and 1, 4 weeks with one of these, man, and then you're out. But in the meantime, we're here for you.
Thank you, Dr. Sheri. And, that's great. Our last poll question really has to do with being able, if you wouldn't mind launching it, Lisa, really mine has to do with how we can get the best information out to you. I will make a couple, I know we're coming to the top of the hour. We have one more topic we want to discuss, but a couple things. We're getting a lot of questions on reimbursement. I will let you guys know that on November 11th, we have a webinar with a reimbursement expert focused completely on reimbursement. So please look out for our emails. You can visit the newsroom page on impediment.com to learn more and register for that. Additionally, we wanted to, like I said, learn more here. So there was, additionally, we have some questions we didn't get to today. We will follow up with all of you individually to make sure we can get answers to your questions. So, before we break, and we've got 5 minutes left, we've talked a lot today about lymphedema, and of course, there's many other aspects about survivorship. So really wanted to ask each of you to think about the question, we titled this webinar, Preserving the Whole Patient. And so when we say preserving the whole patient, what do we mean by that? Dr. Shaughnessy, would you mind kicking off that answer?
Well, I think from the standpoint of a patient, in embarking on the treatment of my cancer, I had major concerns. I certainly identify with being a surgeon. I certainly identified with understanding some of the concerns my patients come to me with. My concern was, how was I going to get through this process and land in a position where I could continue on with my life as I knew it, or as close to it as I knew it as possible? Because certainly I've worked hard to get it to this point. I certainly have worked to a point where I enjoyed what I did, and identified with it. It was part of my own identity, and I certainly wanted to continue to be able to do what I wanted to do and have some quality of life.
Thank you, Dr. Shaughnessy. And before we go on to Julia and Dr. Sheri, I'm going to share the results of the final poll. I think obviously the number 1 and number 2 sources of information are colleagues and professional societies, which I think makes a lot of sense. We have told you guys a lot about a lot of online resources available today. Just wanted to let you know that if you go to impedimed.com, you can find our LDEX provider search tool. Also, if you go to our healthcare professional lymphedema page, you can learn more about our technology, and also we have links through to Dr. Sheri's Live Today Foundation. We also have links through to the Learn Lymphatic Education Research Network. So all of that can be found at impediment.com. Dr. Shaughnessy, thank you for your response. Julia, when you think about preserving the whole patient, what does that mean to you?
Well, for me, because I'm more directly in clinical practice from a rehab standpoint, my main goal is function and what is important to the patient. So I'm really blessed in that aspect that I have a little bit more time to ask those questions. One of the things that I did realize early on was if I was bringing a patient back into the room and I would say to them in our first session, I might say, "How are you today?" And their answer to me is, "Well, I have breast cancer. It's this stage. I've had this much chemo, this much radiation." And I started to realize that people had begun to define themselves by their diagnosis. And I understood it. Even as healthcare providers, we oftentimes will say this person has and list it out. But I found myself stopping them and say, all of that information is very important, and I would like you to share that with me. But I would like to hear how are you as a person today? What are you looking for in the future? My goal as your therapist is not only going to be to help you through this journey, but to know what's important to you and make sure that what we're working on matches what goals are important to you. And I think that's really important, because when you look at people individually, and when you look at people culturally and within family units, what one person may desire as far as independence and ability to perform is not the same as what someone else may desire in their culture or in their age. Certain people, the family unit is expected that they're going to care for them, and they do not want to maybe do a lot of the extra activities that I'm trying to help them with. And so it's really understanding. So for me, preserving the whole patient is learning who is the whole patient and who else is involved in this process and in the treatment, and where are we headed. And for me and my patients, that's kind of where I guess I've grown as a clinician, is learning who they are, and that really helps to drive outcomes and build that relationship for success.
Thank you, Julia. And Dr. Sheri, I'll pose the question to you and ask you your thoughts on what does it mean to preserve the whole patient?
For me, preserving the whole patient is giving that patient back control. When a patient gets a diagnosis of cancer and you tell him or her that they need chemotherapy and radiation, and telling them what their options are, I think 100% of them, and depending upon what stage we are, certainly in these earlier stages, people don't even hear it as a choice, right? Because they want to live. So if you said, I need it, I'm going to get it. But doing something like this, where they're able to get tested regularly, and they have to come in for those visits, and they have to come in for those appointments, that gives them that option to I'm now taking on control of what's going to happen with the rest of my life after I'm done with treatment. I now have the ability to work with my physician and the rest of my team to make sure that I am completely whole. And in order for a patient to really fully take into account everything that has happened to them and transpired in their life, giving them that control is huge. But as a patient, you giving back abundantly in the midst of what you're going through is going to help you heal, because there's less of a focus on you, but yet you're giving to other individuals. So this is on a personal tip level. One of the ways that I was able to heal was to lose sight of me and to be able to give back. So addressing the whole patient, as the patient, you have to be empowered to want to give back. As the physician, you need to have the patience, the compassion, and the empathy to ensure that your patients will do more than just survive, but they will thrive. And then you need to help your patient take control and make a decision that they will choose to live today and every day. And I'm going to add this, and by live, I mean, for me, love yourself and others, inspire those around you, voice your dreams and ambitions, and enjoy life. As a physician and as a patient, make up in your mind that you will choose to live today and every day.
Thank you, Dr. Sheri, and thank you to all of our panelists today. This is really an amazing discussion and a wonderful opportunity to hear from such experts. I did want to share with the audience our upcoming webinar schedule. We have a continued monthly cadence of great information. Like I said, in November, we'll be discussing reimbursement. In December, we have a SOZO user group. This is really intended to help you SOZO users get the most out of your device. It will be moderated by Maureen Macbeth. And then in January, we'll be discussing the prehabilitation model of care in more depth with Karen Hook and Carrie Utendorf from the Ohio State University. So again, thank you panelists for joining us. It's been a wonderful discussion today, and thank you everyone who attended.